All right, well, I'd like to start by thanking everyone, and particularly Aram and Juan, for inviting me to speak today. It's certainly a pleasure to be here and an honor. And though it is, I must say, a tough act to follow after Andrew and Matt before him. My talk is entitled Clinical Trial Updates Targeting the Tumor Microenvironment in Cholangiocarcinoma. There we go. So the first part of this talk is really just to overview what constitutes the tumor microenvironment. There are certainly cancer cells and cancer stem cells, which are the targets of our conventional therapies, chemotherapy, or even the targeted therapies towards mutations in those cells, which Andrew has been talking about just now. But there are many other factors which turn into a very complex interface and an interplay of many critical elements. This figure here shows just a cartoon of some of the more simple, constituents of the microenvironment. But here we have in blue tumor cells themselves, in red cancer stem cells, which are sort of the pluripotent or precursor cells to become the carcinoma itself, and then a host of immune cells which populate the environment, from antigen-presenting cells like macrophages to T cells, and then structural elements like stroma and the extracellular matrix that is laid down by fibroblasts and other cells, and blood vessels, which bring nutrients, cytokines, and circulating factors to this environment. So as you can see, though, again, this is just a simplification of the place that a tumor lives. All of these elements, beyond just the ingredients of the tumor cell itself, can theoretically impact treatment and response. So the objectives of this session today are to really provide an overview of the clinical trials currently ongoing and in development or on the horizon, which incorporate the microenvironment as their target in cholangiocarcinoma. And I really just focused on systemic therapy trials for advanced disease and highlighted sort of the most provocative combinations that we know of right now. First, I'll focus on some immunotherapy approaches, including checkpoint inhibition, adoptive cell therapies, and coupling as a sort of a novel and very early approach, coupling the innate with tumor-specific immunity. And then more conventional strategies like anti-angiogenesis, which has been an established target, and another new area, at least in cholangiocarcinoma, which is stromal depletion. So starting with the immune response, I think in oncology we've all been party to a renaissance the past few years with the advent of checkpoint inhibitors, which are one of the most successful new strategies across different types of solid as well as liquid tumors to help our own immune system activate against a cancer rather than directly targeting the cancer with the drug itself. The checkpoint inhibitors are drugs which block the negative inhibition of a tumor which may have a protein called PD-L1 or PD-L2 on it. The checkpoint inhibitor blocks the negative signal from that protein and allows T cells to recognize antigen on that tumor cell as being a foreign or inappropriate cell in that space and activate the T cell effector mechanisms, leading to anti-cancer immunity on our own by the body itself or elaborated by our own immune system. So immuno-oncology is really revolutionized by the advent of checkpoint inhibitors. And we now have checkpoint inhibitors approved by the FDA for a variety of indications, including first melanoma, but also small cell lung cancer, non-small cell lung cancer, kidney, bladder, head and neck cancer, and Hodgkin's. That's just for PD-1 and PD-L1 inhibitors. And we also should add ipilimumab in prostate cancer as a CTLA-4 different type of checkpoint inhibitor with the same principle. So for the PD-1 inhibitors, a variety of drugs are now labeled, including pembrolizumab, nivolumab, and atezolizumab, others pending. And I think the reason why this is a huge part of our talk today is that early results in biliary cancers tell us that there is the potential for activity in our population as well, in cholangiocarcinoma. So the first clinical trial reporting results of a checkpoint inhibitor in biliary tract cancers was Keynote 28, a trial of pembrolizumab in a variety of different tumor types, which fortunately included a cohort of biliary tract cancers. So 87 patients were screened for the presence of PD-L1 on the surface of the tumors, which is, again, the inhibitory signal that some tumors send to shut down the T cell response to them. And they saw in those 87 patients that about 40% of cholangio or biliary tract, that included gallbladder, had tumor surface PD-L1 expression. that particular trial, Keynote 28, required PD-L1 expression for eligibility. And so of the people that had the tumor, they ended up enrolling, about 24 patients total, and saw that a subset of patients had a partial response. About 17% of patients in this swim plot here had prolonged disease response with the median duration of response not yet reached. So again, not a majority, but the provocative feature of this was not so much the percent of responders, but how long and durable they were. So that has prompted a follow-up study called Keynote 158, with also sponsored by Merck, looking at pembrolizumab, the same checkpoint inhibitor, in a much larger cohort. It's also a basket trial with a variety of tumor types, but they include cholangiocarcinoma, biliary tract cancers, and have enrolled very quickly a cohort of 100 patients with biliary cancers to look at a primary endpoint of overall response. They're allowing patients with PD-L1 or positive or negative tumors to enroll. And one of the interesting findings from this study, once it reports, will be whether PD-L1 expression is required for response or not, since, again, both positive and negative tumors are allowed on the study. And again, I circled here the biliary cohort. So this is a case example I think I shared in my talk last year as well, but I wanted to highlight it again as how exceptional these responses are when they happen. This is an intrahepatic cholangiocarcinoma patient who has experienced a prolonged complete response to PD-1 inhibition, now almost 8 months off drug, and after 2 years on pembrolizumab therapy. There's only some cystic remnant of previous multifocal liver tumors. Prior bone mets and lung mets and a cardiac met have disappeared. I'm not sure if this patient or her family is here today, but it's a remarkable testament to how effective these drugs can be to be able to sustain a complete response 2 years on drug and now 8 months and counting without therapy. One of the points, though, from this patient is as we further interrogated the tumor, we learned that this patient had a microsatellite high tumor, which reflects a mutation panel similar to what Matt described in his own case, where he had an MLH1 mutation on his foundation panel. So in addition to having the biomarker of PD-L1 positivity, this particular patient also had the microsatellite instability. So following upon that clue is of potential biomarker of response, there are also other non-colorectal and colorectal cohorts of patients with this particular pattern of mutations called mismatch repair deficiency or microsatellite instability, which do show an exceptionally high response rate to PD-1 inhibition, much higher than the 17% that we saw in the Keynote 28 trial. The small cohorts that have been studied in the non-colorectal series show about 50% response rate in this people that are enriched for this particular mutation type. So that brings us back to the microenvironment to ask, what are the features about tumors that lead to responsiveness to checkpoint inhibition in particular? And it reminds us again that this is a very complex interplay of a lot of different moving parts, including not only the mutations on tumors themselves, such as the microsatellite instability, but also the clonality and the presence of T cells near them. If the T cells need to be there and potentially have the activation status and the reactivity to respond to those tumors. And then there are other factors in the environment, including cytokines, as well as, sorry, I can't read from this direction, the expression of PD-L1 potentially on tumor and stroma, which again, we don't know for sure the role of this in the response in cholangiocarcinoma compared to other tumor types. So currently, candidate biomarkers for response to checkpoint inhibition include, as I mentioned, the best established, which is microsatellite instability or mismatch repair deficiency. But there are other questions still remaining, including whether PD-L1 expression on tumors plays a role, and if so, how do we measure that, and what are the best cut points, and which cells should we be looking at, the tumor cells themselves or the stroma around it in the microenvironment. There's also a question of the number of mutations. Does a high mutational burden or tumor mutation load confer responsiveness? And certain types of mutations may be more likely to create a novel antigen or a new protein on the surface of a tumor that's really recognizable to the immune system. And that may be predictable if we do tumor sequencing, focusing back to Andrew's talk, and then look at the actual structure of those proteins. So moving forward from that arena of using checkpoint inhibition, I think another fascinating approach is to take the same process, and instead of giving a checkpoint inhibitor to the whole body, take the cells outside of the body and try to engineer this reactivity in the lab, which is a strategy that's been pioneered by the Rosenberg lab at the National Cancer Institute called Adoptive cell therapy, where a tumor is taken out of the body, a small amount in a surgery, and that autoreactive T cells are identified that happen to respond to the tumor antigens. And then those T cells can be expanded and reintroduced in large numbers back into that same patient after some chemotherapy to lymphodeplete or make a fertile ground for the reinfusion, and achieve a tumor response that's very specific to the target antigens of that tumor. And so another example in cholangiocarcinoma, this strategy has really been most successful so far in melanoma, but a few years back, a patient with cholangiocarcinoma was found to have a remarkable response to tumor-infiltrating lymphocyte, or this T cell, adoptive T cell transfer of tumor-specific lymphocytes. Another immune approach that I think is of quite fascinating promise, not yet in practice or in play for cholangiocarcinoma, is the potential for coupling the innate immune response, so that our response to normal pathogens such as bacteria or viruses that our bodies are used to fighting off, to tumor-specific immunity. And a strategy for doing this has been piloted by Aduro with their Listeria vaccines. And something ahead on the horizon potentially for cholangiocarcinoma clinical trials is the concept of a personalized, live attenuated, double deleted Listeria vaccine, wherein the virulence factors or the infectiousness of the vaccine, of the Listeria itself, has been deleted, and instead introduced have been the antigens that are associated with an individual patient's tumor. So taking the mutations, as Andrew discussed, that are sequenced out of a tumor, inserting that into the DNA of the Listeria, and then showing that to your immune system so that your immune system has the innate response to the Listeria bacteria, something that's very familiar to our immune system and elicits quite a significant immune response, and then showing that in parallel with some of your tumor so that then the immune system can see both of those and mount a tumor-specific immune response at the same time, primed by the Listeria innate response. And so this is leading to the development of a potential clinical trial that we hope will have a cholangiocarcinoma expansion cohort in the future, depending on its results. So shifting gears to a more established, long established, I should say, microenvironment target. Beyond the immune cells in the microenvironment, there are also blood vessels that carry those immune cells, as well as a variety of other factors to tumors and allow for their growth. Anti-angiogenic strategies blocking blood flow or blocking tumor blood supply have already been established to improve survival in a variety of gastrointestinal cancers, including colon, gastroesophageal, and hepatocellular carcinoma. And there's been some promising early results in cholangiocarcinoma suggesting there may be benefit of this approach in combination with chemotherapy as well for biliary tract cancers. And this is work from Andrew and his group in 2010, when they showed that the combination of Avastin or bevacizumab plus Gemox was associated with promising response rates and prolonged progression-free survival in a small cohort. Since then, though, a variety of studies have shown the difficulty of combinations in cholangiocarcinoma, and we've seen that the tyrosine kinase inhibitor strategy, where a small molecule inhibitor of anti-angiogenesis, often coupled with other targets at the same time, have yielded relatively high rates of toxicity and not so much of a signal of efficacy in this context. And that includes a combination with sorafenib and erlotinib in the SO941 trial, cabozantinib in second-line advanced biliary cancers, and the ABC03 trial in the UK, where cediranib versus placebo were tried in combination with Gemcis as first-line therapy. And all of those have been very difficult studies without significant signal of efficacy, but again, challenged by toxicity. A trial I wanted to highlight that's ongoing is the JSBF trial, which looks at a different anti-angiogenic agent, ramucirumab, which has shown its safety and tolerability in other gastrointestinal cancers, including stomach cancer and colon cancer, and it has a variety of FDA labels for these indications. There's a trial now going on looking at ramucirumab plus Gemcis as the first-line combination in cholangiocarcinoma, paired with a parallel arm of a MET inhibitor, merestinib, which is more of a targeted therapy along the lines of what Andrew was discussing. But I think that particularly from the concept of a microenvironment approach, it'll be very interesting to see how this placebo-controlled trial of ramucirumab plus Gemcis versus placebo plus Gemcis plays out with respect to efficacy for a drug that we know is more tolerable generally than the tyrosine kinase approach to anti-angiogenesis. So moving forward into another new and I think very exciting and different approach to targeting tumor microenvironment in parallel with our conventional chemotherapy approaches is the concept of modifying tumor stroma. So I mentioned earlier that tumor stroma is sort of the structure of a cancer. It's the extracellular, often acellular matrix of fibrosis and fibroblast cells that lay down collagen and a variety of other substances to support the blood vessels and the work of an organ. Often, though, tumors elaborate a dense stroma around them, and that may interfere with drug delivery as well as the immune response that we're hoping to elicit with some of these immunotherapy strategies. In cholangiocarcinoma, we see a desmoplastic or a very thick fibrotic stroma reaction very similar to pancreas cancer in many cases, and a study of 142 cases in a registry have shown a very high level of stroma hyaluronic acid, which is part of the collagen extracellular matrix. So there's a variety of studies ongoing following upon, or in pancreas cancer in particular, to study this question of stromal depletion. The one I wanted to highlight today is the farthest along, which is human hyaluronidase, which is an enzyme called pegylated rHuPH20 or PEG-PH20, which depletes the hyaluronic acid in the extracellular matrix or stroma. In cell lines, we can see, or in preclinical experiments, we can see a decrease in smooth muscle actin, which is a marker of this matrix, with a combination of gemcitabine plus PEG-PH20 compared to gem alone, as well as decreased collagen in green when you use PEG-PH20 plus gem compared to gem alone. And this allows for what the contention is, this allows greater vascularity and potentially greater drug delivery or even immune response in these cases. So in pancreas cancer, a recent study called HALO 202 recently reported very interesting results showing that patients with high hyaluronic acid levels had a much higher response rate than those with low hyaluronic acid levels to the combination including PEG-PH20 with chemo, and also a correspondingly significantly higher progression-free survival. In pancreas cancer, this has led to an ongoing randomized phase 3 trial of gemcitabine plus nab-paclitaxel plus the agent PEG-PH20. And I'll come to a potential combination trial in the future where the same approach might be useful in cholangiocarcinoma. So to conclude, I'd like to highlight some of the combination approaches we're starting to see, which really look at the cancer as a part of a microenvironment rather than a standalone set of cells. So as I mentioned before, autologous tumor-infiltrating lymphocytes or adoptive T-cell transfer is a way of taking the T-cells from a tumor and expanding those that are particularly reactive to tumor or engineering them to be reactive to the tumor. There are studies now going on at the NIH or NCI combining TIL therapy or these adoptive cell transfer to a checkpoint inhibitor, pembrolizumab, to see if that will further increase the likelihood of response or durability thereof. We also see with a cholangiocarcinoma cohort the combination of CTLA-4 plus nivolumab, which has a cholangiocarcinoma cohort in an ongoing trial at the NCI. We have a poster today of our work at UCSF looking at GM-CSF with the intent to expand antigen-presenting cells and bring them to the microenvironment in combination, again, with a checkpoint inhibitor. Sorry, I should have highlighted the recurring theme that all of these combinations right now are the majority include a checkpoint inhibitor, which is true across cancer types. But here's another interesting example, harkening back to Andrew's talk again on, this is an FGFR2 inhibitor for FGFR fusion patients. There's now a study ongoing combining an FGFR2 inhibitor to the checkpoint inhibitor pembrolizumab in hopes of potentially augmenting the immune response by eliciting a cytotoxic response in FGFR2 fusion tumors cells and allowing them to become potentially more immunogenic. Finally, there are trials ongoing, including this chemotherapy combination here at University of Utah, looking at pembrolizumab or checkpoint inhibitor plus conventional chemo, or with ramucirumab, a sponsored trial from Lilly and Merck, looking at the combination of their anti-angiogenic agent plus pembrolizumab. And lastly, in development is the concept, which I'll show a schema for in a moment, of the stromal depletion strategy I just finished with, plus a PD-1 inhibitor. So in the interest of time, I'll conclude with this summary that the tumor microenvironment represents a very complex interface, including tumor, cancer stem cells, host stroma, and vasculature, as well as circulating factors, and we certainly don't understand this interplay. But we have been extremely gratified across oncology with the results of immunotherapy, particularly checkpoint inhibitors. which have shown durable responses in a subset of patients with cholangiocarcinoma, and has launched a next generation of clinical trials, including the table I just showed in cholangiocarcinoma, with the attempt to harness the immune response and augment it by combining with other strategies, including other strategies in the microenvironment like anti-angiogenic approaches or stromal depletion. On the subject of checkpoint inhibition, it's very important to highlight, as Matt's experience did, that microcellular instability or mismatch repair deficiency are associated with higher response rates, and that there are many other biomarkers which we need to understand more fully to predict who's likely to respond. We also, I think, adoptive cell therapies and vaccines are extremely promising to help tumors recognize the specific targets we'd like them to. And these combination strategies, I hope, will be the future of our part of the future of our approach to cholangiocarcinoma. Thank you.